Well, hello everyone. My name is Alex Keller. I'm the medical director at FullScript, and thank you very much for joining us today. I have the esteemed pleasure of introducing our special guests today who are going to be presenting on a very important topic in our current health landscape. What's exciting about this as well is that this has been a program and a protocol that's been in development for about 2 years now, and FullScript has been in partnership with Ovation Lab on bringing this to market to practitioners like us for about a year. So this is an update on where they have come with this protocol, and it's very exciting for us to be presenting this content, and I'm excited to be attending this with you. So just a few housekeeping notes before we get going. Obviously, as always, this webinar will be recorded, so if you have to drop off early, or if you're just tuning in after the fact, then you can have access to this. We'll also be sharing the slides and some additional content after the fact on the same registration page that you used to register for this. So we'll send you an email after, or you can go back to that page for additional resources. And before we start, I do have to read this disclaimer because of the sensitive nature of the content in this presentation. So just bear with me. This content provided is for healthcare practitioner informational purposes only and is not a substitute for your professional judgment. We expressly deny that the information being provided is intended to assist in the cure, diagnosis, prevention, or treatment of coronavirus-related diseases. You should always exercise your professional judgment when reviewing scientific literature. So thank you for listening to that. Now we'll introduce the speakers. And again, I have the esteemed pleasure of introducing Lori Hoffman, who will act as the host for the majority of the presentation today. I'll jump back in a little bit later on. And your presenters with Lori will be doctors Patrick Hanaway and Kara Parker. Lori, I'll pass it to you.
Thank you, Dr. Keller, and thank you to FullScript for giving us the opportunity to present this information today. We're actually very happy, pleased, excited to be here. So let's dive right in. We have a full packed hour planned. So next slide. What we're going to cover today is taking a look at the current long COVID landscape. We'll provide some updates, as Alex mentioned. Dr. Hanaway will dive into the 5 drivers of long COVID and present an overview of the 90-day program and protocol. Dr. Kara Parker will present on group visit programs, a variety of models that are underway with long COVID and post-viral syndrome. Dr. Hanaway will come back and talk a little bit about some of the outcomes that we're seeing and some refreshed data from our patient registry. And then Dr. Keller will join to do a brief demo of how easy the integration of this protocol is with FullScript. And then we are really hoping to have a solid 15 minutes or so for a panel discussion and Q&A. So please do be posting your questions as we go along. We very much want this to be interactive and to serve your questions and needs. Okay, next slide. I think there's one just before this. Yes, thank you. So let's, I want to provide a little context for both this presentation and the discussion. And let's start with the current landscape. At this point, greater than 80% of Americans have had at least one COVID infection. Most long COVID cases continue to occur in individuals who have had a mild acute illness. This has turned out to be very different than what we understood or thought we understood early on. And then 1/3 of the people with long COVID have no identified pre-existing conditions. One of the other stats just to draw your attention to for context is this last bullet in the right-hand box. The estimate is 2 to 4 million Americans are living with post-COVID symptoms a full 12 months after their acute infection. There's still no proven therapies and there are no standards of care. So making the work that we're doing and the outcomes that we're tracking both very much needed and very important as we all continue to understand more about post-viral recovery. Next slide. Harvard economist David Cutler estimated the total cost of long COVID at $3.7 trillion. So we're including this information again as a component of the context and the landscape of the magnitude of this problem. And it's not just the direct costs of medical spending, but also the estimates on reduced quality of life, reduced productivity, and reduced earnings. So very, very significant. Next slide. Another piece of the current landscape, again, I think there's one slide before this. One more. Okay, yes. Yes, right? One just before that, please. There we are. Perfect, on the RECOVER trial. Thank you. We are juggling using a new platform here, and also someone is graciously agreed to run the slides for us. So apologies for that little hiccup. Anyway, as most of you are likely aware, in December of 2020, Congress funded the NIH with $1.15 billion to establish the RECOVER initiative, which was expressly intended to look at promising therapies for long COVID. To date, I think we've all been somewhat disappointed that the studies have been primarily epidemiological studies that have been descriptive, looking at and categorizing symptoms rather than really addressing or studying therapeutic interventions. As you can see in this slide, there are 5 main areas that RECOVER is focused on. And as of the end of July, or actually just about a month ago, there are now 2 clinical trials that are underway. One that's addressing viral persistence using Paxlovid, and one that is addressing cognitive dysfunction using some online and web-based or app-based behavior training and cognitive training software programs, including Brain HQ. So we look forward to a lot of data coming out of these trials as they really get underway. But as I said already, it really underscores the importance of us all continuing to do the work that we're doing to try to advance understanding across the board about not just the pathophysiology and mechanisms and risk factors for long COVID, but also what we're learning about treatment. Next slide. The other piece that I'd love to introduce here is a very recent survey from Medscape, a physician survey. There were 432 respondents, and 78% of them were family medicine and internal medicine physicians. The others comprised of cardiologists, rheumatologists, and pulmonologists, those specialists that are most likely to be seeing patients with long COVID. So this first finding, which we found very interesting, is that in response to the question, are you seeing more, fewer, or the same number of long COVID patients compared to a year ago? While we hear many reports that physicians are not seeing long COVID patients, in fact, these findings and our own findings demonstrate that that's not what we're hearing and seeing. So here, 48% of the respondents reported seeing fewer long COVID patients, but 52% reported seeing the same or more long COVID patients compared to a year ago. Next slide. This next question asked, how often have you had success with treatments that have benefited patients with long COVID? And really, we were quite shocked to see that only 6% of the responding physicians said they regularly have success with long COVID treatments. And a full 94% said that they never have success with treatments, never have or only occasionally have success with treatments for patients with long COVID. And on the right here, we brought in this quote from a clinical epidemiologist, Dr. Ali from Washington University in St. Louis, in which he's really unrelated to this survey, but in another article published just a few weeks ago in Stat Health Tech, he really talked about that long COVID doesn't appear to be self-resolving in the sense of either spontaneous recovery or recovery in the absence of a cure. And he further stated that it reinforces the importance of continuing to look for and find treatments because this is not going away. And I think you will hear both Drs. Parker and Drs. Hanaway underscore this point. Next slide. The last piece of survey data that I wanted to highlight here is in response to the question of how informed do you feel regarding potential treatments for long COVID, only 10% of the physician respondents said they felt well informed. 90% felt only somewhat informed or not well informed. And the frustration that is being experienced across the healthcare professional community is conveyed here in the quote on the right. So again, these survey data, the studies that we're going to refer to and present during this presentation really underscore significantly the need for more education on the drivers, the pathophysiology, mechanisms, and risk factors of long COVID. Yes, all very important to continue learning and understanding, but we really need to be turning more and more attention to promising therapies and treatment approaches that include patient registries and outcomes tracking. So this is a good segue into Dr. Hanaway's presentation, and I will be back just a little bit later to facilitate our Q&A. So Patrick?
Thank you so much, Lori. If I could get a cue that y'all are hearing me fine, that would be great. Hello, hello.
Yep, we can hear you, Patrick.
Okay, great. All right. So if we could go to the next slide, what I'm going to be focusing on is looking at those aspects of the 5 main drivers that we've seen through our, research and evaluation of the literature. So going back to 2021, as we were recognizing, and I would say that the group I've been working with began to recognize in literally April of 2020, 1 month into the pandemic, that the post-viral process that was going on was going to have severe implications for people, as we've seen historically over time with viral illnesses. We've talked about this previously in the past, but what has begun to be understood, it was first the awareness that there are 2 main regions. One is the chronic inflammation that goes on, and the other is in relationship to a ACE2 mediated tissue damage that occurs, as we see discussed here in one of the earliest papers. Next slide. And as we went into that and looked at the work of Crooks et al. Out of the UK, and they began to look at all the various tissues where ACE2 mediated damage was occurring, what we highlighted, next slide, was that really the key areas were in the lungs, the respiratory issues, the heart, the myocarditis, and the vasculature, the brain, the microbiome, and the mitochondria. And so looking at those areas, we began to put together an understanding of, well, what are the 5 main drivers that are happening here? Next slide. We began to see this interrelationship that goes on between the microbiome. There's a clear signature of people who get long COVID, and there's who are at risk for it, and a clear signature of people who have long COVID of alterations in their microbiome. Now we know as root cause practitioners, functional medicine practitioners, that what's happening in the microbiome informs and educates and deeply influences the immune system. So we see that interrelationship. We've also begun to see a key relationship between the microbiome and the mitochondria, as well as the immune system and the mitochondria in terms of overall energy production. Next slide. So what we began to put together were 5 main drivers: the ACE2 mediated damage, the chronic inflammation that we see in the middle, that chronic inflammation that influences the mitochondria and is influenced by it, that influences the microbiome and is influenced by it, and the presence of viral persistence in at least a subset of the cases. Now, it's been reported that somewhere between 20 to 50% of the issues with long COVID may relate to viral persistence that's going on. We'll talk about our data of working with a number of people, more than 40 people who have completed our registry, where their average length of time with symptoms of long COVID from their first infection is 1.8 years. So we haven't seen viral persistence lasting that long, but we have seen it in other patients palpitations, and we need to take care of that as well. So our approach has been to say, okay, how do we work with these 5 primary drivers that are going on? Now, next slide. As we've gone into this, and seen the interrelationship of these things, you can't just pick one thing. You can't just say, oh, this person has damage, this person has chronic inflammation, this person has viral persistence. They're intimately connected with each other. Next slide. And what we've seen since putting forth this idea that we see here of these 2 primary areas between ACE2 mediated tissue damage and immune dysregulation manifesting itself as through viral persistence or mitochondrial dysfunction or microbiome dysfunction, has been a validation of our view from the peer-reviewed literature. Next slide. So this paper from Hannah Davis and the chief author of Eric Topol, who's the editor for Medscape, in January of this year in Nature Reviews Microbiology, talked about the principal aspects that they saw of dysfunction that were going on, dysfunction that relates to viral persistence, microbiome dysfunction, chronic inflammation and vascular issues. Now, they also define neurologic symptoms as a hallmark of it, and we do see that. But from our perspective, those neurologic symptoms are mediated through alterations in the gut microbiome, in the glycocalyx, the damage that occurs there, viral persistence, as well as mitochondrial dysfunction. So we're looking at drivers, at root cause drivers that are going on rather than symptoms. Interestingly enough, next slide, what they have recognized is not only the fact that viral persistence will have implications on causing further tissue damage, causing further chronic inflammation, causing reactivation. This has been well known and documented of seeing activation of Epstein-Barr virus as well as human herpes virus 6. But next slide, we've also seen mitochondrial dysfunction that's going on, which is part of what we talked about. So we have more recent work from Dr. Topol, that just over the past 2 months has continued to validate the mitochondrial dysfunction as a key piece. And here we see research which shows that viral binding to the mitochondria is actually part of alterations in the electron transport chain and the ability to produce energy. Next slide. And then finally, the work of Dr. Pretorius out of South Africa that has talked about alterations due to ACE2 mediated damage, and that the ACE2 receptor, when it's bound with the spike protein, can lead to cytokine productions, which leads to neutrophilic extracellular tangles or nets that we see there, and the production of a fibrin amyloid combination microclot. The microclots that are present because of disruption of the endothelial glycocalyx, leading to clotting, which may relate to some of the early issues that we saw acutely, but also one of the things that Dr. Pretorius and Dr. Bruce Petrino at Mount Sinai have seen is a persistence of microclots that are present in most patients with long COVID. So is this a single thing? Is this the answer? Probably not, because we have to look at those other primary drivers that are going on. Next slide. So that's what we've done with our program and protocol, is said, well, let's look at these 5 primary drivers and begin to understand how can we effectively influence them. And we've worked to put that together, gathering some different kinds of supplements, but next slide, also recognizing the importance of lifestyle, that modifying the diet and food and nutrition. If people are eating a pro-inflammatory diet, they're not going to be able to get better. If people are eating a high glycemic diet, which will increase the ACE2 receptors, or increase the activation of the ACE2 receptors and increase the disruption of the endothelial glycocalyx, as well as the blood-brain barrier, which is made of glycocalyx, you're not going to get better. So working with each of these individual components. So we take a health history and we look at the timeline and progression of what's gone on. We're putting this data together because we're trying to see, can we substratify the patients into different categories? At this point in time, we don't see that. We see that that there's the constellation of symptoms does not actually indicate one particular form of viral persistence or mitochondrial dysfunction or microbiome dysbiosis, or chronic inflammation. So we then work with a program that emphasizes the lifestyle components, and then brings in some different kinds of supplements to be able to help those 5 primary drivers that are going on. So in that root cause approach, next slide. In that root cause approach, what we're doing is we're then evaluating the data and tracking it, saying, okay, what's happening at baseline? What's happening at 30, 60, and 90 days? We're gathering data using something called a post-COVID function score, which was developed in early 2021 in Europe to be able to get a general overview of activities of daily living. Is someone bedbound? Are they not able to perform any of their ADLs? Do they need support to do some of their ADLs? Are they able to do their activities of daily living, but they're much reduced in their capacity to do that? Or do they have full function? So those are sort of the 4 points of the post-COVID function score, which I'll talk about our data a little bit later. And then also looking at patient-reported outcomes measures, including the PROMIS 29, which measures not only physical function, but a series of other domains that look at fatigue and social engagement, that look at depression and anxiety and sleep. And we'll talk about the data that we see so far. Next slide. So initially, again, we start with the lifestyle interventions, looking at a Whole30 kind of dietary approach, whether it's an omnivore or a vegetarian approach. It allows for the ability to do that, working to help to ensure that there's adequate sleep, which we know insufficient sleep can be a driver of chronic inflammation, making sure that there's movement and exercise. But it's also particularly difficult because we can't push too hard. We have those patients who have the principal hallmark of post-exertional myalgia that is seen with chronic fatigue and myalgic encephalitis. We can't push them too hard, but we do want to be able to get them moving and doing some exercise, because we know that's one of the factors that will increase the efficiency of mitochondrial function. So the engagement with people, and as we'll hear from Dr. Parker, even using group visits as a means of helping to enhance the social engagement and support with each other. These are all factors that are necessary first steps. Next slide. So what we see is that those aspects of, and you can click also there, Sarah, the aspect of lifestyle and the aspect of nutrition are fundamental hallmarks for dealing with these 5 principal drivers. And then we also have some supplements. And what I'd like to do is I'd like to talk about the approach that we're taking in relationship to those 5 principal drivers. Next slide. And so when we look at okay, jumping around here. Again, those 5 drivers: ACE2 mediated damage, viral persistence, chronic inflammation, mitochondrial dysfunction, and gut microbiome dysbiosis. So the first one that we'll talk about is about ACE2 mediated damage. And we've seen some of that. Next slide. We've seen some of the data from Pretorius, and what we're finding is that there is a particular agent, a rhamnum sulfate, that is a repair agent for the endothelial glycocalyx. The glycocalyx is involved in dealing with vascular permeability, vascular dilation, and regulation of blood pressure, production of nitric oxide and superoxide dismutase. Each of this agent is effective for helping to heal and repair the lining of the endothelial glycocalyx. That's where the ACE2 mediated damage is occurring. That's where the microclotting is occurring from the disruption of that glycocalyx. So that's the first approach that we're taking for ACE2 mediated damage. Also note that I said that the blood-brain barrier is a form of glycocalyx that is also disrupted and needs to be repaired in patients who have this tissue damage that's occurring. Next slide. And we go into looking at viral persistence, and in viral persistance, we have recognized, you'll see the term there of a 3CL. CL means chymotrypsin-like, but we've heard 3CL protease inhibitor, and certainly there are pharmaceuticals that are on the market that are used for acute COVID that have been FDA approved that are this type of protease inhibitor, which inhibits the viral replication process from occurring. But in the setting of long COVID, in terms of trying to treat what may be a viral persistent pattern that's going on, or a persistence of a component like the spike protein that's present there, we are using this 3CL protease inhibitor that's been well known as a Chinese herb called zikao that has known antiviral properties, but it actually has this gromwell root or red root has been well studied in terms of its ability to actually be a ligand that binds the 3CL protease and inhibits that function from being able to occur. So this is the tool that we're using for viral persistent. Other things like Paxlovid have been, there are trials that are going on right now. One at Stanford that was stopped, one at Yale that is continuing to go on, but have not yet been able to demonstrate its effect as a pharmaceutical agent. Next slide. In terms of chronic inflammation, we looked at a series of different kinds of tools, including turmeric and boswellia, but what we focused in on was that the Chinese skullcap, Scutellaria bicalensis, was demonstrated to be able to have a significant impact on the NLRP3 inflammasome. And there were studies done looking at acute COVID where there were significant disruptions and changes from the use of Chinese skullcap. So we've taken that and we've used that as the primary anti-inflammatory approach, along with other agents like boswellia, frankincense, and turmeric to be able to get a beneficial effect, and then using those things that we've used for a long period of time as anti-inflammatory measures, like the omega-3 fatty acids that will have an effect on the anti-inflammatory prostaglandins to be able to support them, as well as vitamin D, quercetin, and antioxidants. So we have a combination approach that's really focused on this chronic inflammatory process that's going on. Next slide. Next slide. In mitochondrial dysfunction, what we've done is we've looked to say, well, what are the vitamin and mineral cofactors that are involved? And we can see to the right here the electron transport chain, where we know that carnitine and magnesium and CoQ10 and riboflavin and niacin all have a very important effect, and that we need to have these cofactors. If we look at the next slide, we can see within the Krebs cycle, I think there was a slide that was missed there, but let's just go back one slide. The Krebs cycle also has an impact of where there are necessary vitamin and mineral cofactors. And of course, when there's oxidation, it decreases the efficiency of the mitochondria. So we need to have the antioxidant support using plant-based antioxidant support primarily, as well as alpha lipoic acid and the the tocopherols. And magnesium is also a principal agent. So we're nutritionally supporting the mitochondria. And then finally, next slide, we go to the microbiome. In the microbiome, we're using a spore-based probiotic to help be able to cause a shift in the system itself. And then essentially the essential aspect of using prebiotics, prebiotics that are meant to be able to restore the beneficial bacteria that are going on, increasing the production of anti-inflammatory bacteria like Akkermansia and Faecalibacterium prausnitzii. So we've taken this 5-step approach, next slide, to be able to work to really lift all boats. We're working to have the people who have long COVID be the healthiest long COVID patients. Click on that again, because when we use the lifestyle and nutrition to support them overall, and then use these other agents to be able to help be able to focus on these 5 principal drivers, we have the opportunity for healing to occur. So I appreciate that, and I want to turn it over to my friend and colleague, Dr. Kara Parker.
Thank you, Patrick. Are you able to hear me with my
Yes.
headset on?
Yes.
Great, thank you. We've got some fantastic thunder happening, so I apologize if there's sound disruption. So we shared that 90% of clinicians feel that they don't have enough information on long COVID. And imagine, watching this webinar, how your patients are feeling with that. And we have found that pulling this program, this protocol into a group medical visit type of a format is a fantastic way to deliver the information really efficiently. I've been doing a lifestyle-based group for about 3 years for long COVID, and in the past year have been adding the protocol supplements to it. And it ends up being about 14 hours of patient time that, if you imagine trying to do that one-on-one with people and deliver enough information and empowerment and resources for the type of help that people need when they've really been sick with long COVID. So let's dive in a bit. Next slide, please. And Patrick, I think somebody's got a mic on perhaps. So the components of what is available with group medical visit format, you really have time and emphasize being able to scale the education. Like I said, 14 hours, how would you have a single one-on-one patient in your office for enough time to be as in-depth and comprehensive in education on long COVID, on the drivers, on the lifestyle changes, and on understanding what the supplements are and how to take them. So also, additionally, beyond a one-on-one, you've got time for support, for questions. We often find when we gather people for 2 hours that by the end, people really feel satisfied, like they come to the end of their questions for that time period. And I don't ever have that in a one-on-one visit. I don't know about you as practitioners if you have longer visits, but it's a really rich and satisfying way to set up delivery of this type of medical care. Next slide. And whether a practitioner is billing insurance or is private and can actually be a little more innovative and creative with the groups and not have to fit it into the insurance-based model, both of those work well with this protocol. So in an insurance-based model, that's how I practice. We're billing a 99213 or 99214, usually based on diagnostics codes. By the time you have someone with long COVID and the symptom complex that they have, any social determinants of health issues, and any pre-conditions, you've got a lot to base your billing on. And notes are templated, so they're really easy then to fit in personalized information. And we do this pretty creatively. We can use the HPI through questionnaires that we send out ahead of time through MyChart messages. We ask questions in the chat. We have people raise hands and we record that. And so you can get a lot of personalized HPI simply. It doesn't take a lot of time. You can copy and paste it into your note. And then making sure you personalize the plan in documentation as well to each person in an insurance build model. We do have practitioners using our protocol who have developed group visits and have created a variety of innovative packages. So you can pay per group visit session or pay monthly, as some do, like a group subscription. And you can utilize the practitioners that you have in your office without worrying about who's able to bill, who's not able to bill. Document for the pertinent information you need to remember, not necessarily as thorough of documentation as I need to do for insurance billing purposes, for example. And then one of our practitioners actually does a lot of education by pre-recording videos on some of this information, as you heard Patrick describe on the drivers of long COVID, on the supplements, and then they leave the space for the group as really personalizing the questions and letting the group have time together to have that rich support. And those are 1 hour type of groups. So lots of practice models can incorporate this protocol, the lifestyle and supplements as we've created it here. Next slide, please. So you're gonna, as you pull people into a group, you really leverage that time for connection in whatever model you're working under. Empowering patients to realize that even though they're sick and their lives have changed and their capacities have changed, they have gifts to contribute by nature of going through this and learning what they've learned, sharing from those pearls that they've gained of things that help them. It's invaluable to their peers. So we create a lot of space for that type of sharing and for people to feel that they belong to something and that they are really contributing to something, which can be a rare experience, especially if they're sick enough to maybe have lost employment, to not be able to participate in family events as they normally would have. Ours are on Zoom, and we do a lot of pair sharing so that people gather together and can create even closer bonds with each other, and then report out on what they've heard. Can also use a group to dig deep into teaching on the drivers of long COVID. I often joke with our participants. I work with a very underserved, low social determinants of health population, and they're sent to me from our long COVID clinic, often having long COVID for 1 or 2 years and being sick enough to still need care, even when our long COVID clinic is kind of checked out and has done what they can do. So it's amazing to have, when they've had that much care for their long COVID, to have so much more to teach them about than what they've learned so far from their practitioners. So going into a deep dive into the drivers of what is contributing to their symptoms, and people really want that information. So depending on how brain fog the group is, we keep it as simple or as complex as the group can handle. And then we give them a lot of information after. So they want the PowerPoint they've just looked at. They want handouts. We MyChart message those. And in our post-viral recovery package on the resources page, there is innumerable resources on lifestyle, on the supplements that you can use easily to share with patients. And then we share practices together also. It's a great space to help people learn some skills for working with their autonomic dysfunction, for working with the anxiety and fatigue, for working a mind-body practice that even if they had one before and it isn't quite enough for them, what are some other skills we can pull in? And we really utilize our group members for sharing breathing exercises, eye exercises they've learned with each other as well. Next slide, please. You can see some of the topics here. There's a wide range of topics that all relate. And if for those of you who are trained in functional medicine, you know the tax theory, right? That if you're sitting on 10 tacks, removing half of them doesn't necessarily make you feel 50% better. So we have to work with food and nutrition, with optimizing sleep, with getting people moving, as Patrick said, in that way that's balanced and doesn't cause or worsen post-exertional malaise, but does give them some mitochondrial support, some mood support. Working with breathing techniques. autonomic rebalancing techniques, helping them with mood and mental health, modify stress, understanding and working with brain health and brain fog, optimizing the microbiome and replenishing that, and working with mitochondria. These, as a primary care practitioner, boy, I tell you, primary care does not have time or space for these types of topics. We're supposed to be working on lifestyle, but the space to do that is slim. And so pulling people out into this type of a community where you can really go into these essential topics to help people with symptoms and help people to heal is great. Next slide. Some of our practitioners who are building group visits for long COVID often have questions about how do you recruit patients when you may have a certain number of long COVID patients in your practice, and some of them might want to join a group visit, but how do you really scale it and make it sustainable? I find that our long COVID clinic is more than happy to share patients. They're bustling at the seams, and they have a cardiologist, respiratory therapist, occupational therapist, PM&R doctors, nephrologists, ID people that all share in the care of a patient. And at the end of all of that, patients may not have learned about some of these other essential things. And so they're more than happy to hand them off or simultaneously work with me. So if you have a long COVID clinic in your area, introducing yourself to them, and that you would be sharing in the care, certainly not in any competition to the work that they're doing. That's essential. Other specialists in your community that you may have relationships with that find that they're dealing with long COVID. I tell you, our pulmonologists, even our ENT practitioners, our neurologists who test for POTS are very happy to share some of their patients with POTS for this type of programming. Our psychologists who are working on the new and differing diagnoses and symptom increase post-COVID, etc. And then colleagues, and especially if you work with colleagues who do full spectrum functional medicine, it's a great addition to that complete matrix care. For me as primary care, having patients have a primary care clinician that's not me, so I can focus on this type of work, works really well as well. Next slide. So it's a simple package, actually. This is about as easy as it gets for, I'd like to start a group visit around doing this. How do I possibly do it? It can be quite simple. If you have technology to do a Zoom visit, virtual works really well for people who are tired and who already might have a lot of medical visits. So we do ours weekly. We have a 7-week session. 2 hours per session in our case for our colleagues who are not billing insurance and who see patients one-on-one. They do the group care in 1 hour. And really the clinician, if you need to bill, or a provider who knows about long COVID, plus some kind of a facilitator for the group, health coach, nutritionist. Bringing in guests is fantastic. People love to hear from other practitioners on how to work with symptoms of long COVID. We bring our chaplain in to work on grief, for example, and people find that invaluable to name that there is grief in the loss of function and that they can work on this and share together. Next, thank you. Feedback on this type of programming. People really say that learning from each other's questions, what they bring and what they ask a clinician, what they ask me in the group visit is very valuable. It helps their engagement. They want to have that written down. They want to look back and reference it. And so we're careful to document what we talk about and to share it with them. And then receiving recognition for their own worth, for their own ideas, for their own struggles, and for the things that they've figured out is very empowering. I work with a population that empowerment for their medical conditions is they often come in not having that experience in their life. And so this may be the first experience where they have felt that they've taken steps for their own health and that they've influenced someone else's health by their actions and their sharing. And that it's hard to weight that value, but it's at that point that people really take off and start making positive changes for themselves. We have participants bring in articles. One just recently brought in a recent article on serotonin, low serotonin associated with long COVID. And we pulled that up, reviewed it together, talked about it personally to each of the 13 people in the group. And that was really great, a demonstration of how to look at literature, how to talk with your clinician, how to think about it for yourself, and find ways to make your own shifts. And then the practice of doing this together. So starting the protocol of supplements and sharing it with a group and talking about each other's experiences and questions, watching someone you care about start to improve actually feeds your own joy, your own hope, your own belief in yourself and your journey, and just happiness for others. So it's a great way to scale the benefits of taking the supplements that we've pulled together to address the drivers. Next slide. So as we think about the whole web of long COVID, it's really important for people to have access to functional medicine, quite honestly, to work on the web of their health, the general health, their comorbidities that they have before they came into long COVID and that may have worsened during the long COVID experience. It's important for people to have access to primary care and to draw on the experience of colleagues who are doing great work in this field. Some of our respiratory therapists, our occupational therapists are just getting fantastic at helping people with the post-exertional malaise, the breathlessness. And, that is something that we don't directly address in the protocol. Working with people in mental health, also to help with people's comorbid conditions or worsening conditions. In my practice, we find that working with social workers and helping people on their financial insecurity, their housing insecurity, their food insecurity, medication insecurity, even access to medical care at all is another important thing. You can help people with, getting inflammation down, but if their life remains in an unsafe environment and has that additional inflammation, you haven't worked their whole web yet. You haven't completely addressed all the tasks that are driving the worsening or continuance of symptoms. So my kind of overarching view is that this protocol works really beautifully. Sometimes it's all patients need. If they came in with few comorbidities, long COVID is what took them down, people can get better very rapidly. And then you widen the web as people need, and you offer support that matches what's in their web. So next slide. With that, I'll turn it back over to Patrick. Thank you.
All right. Thank you, Kira. Can you just confirm that you're hearing me?
Yep.
Great.
Can hear you.
Okay.
Thanks.
All right. So let's look at the next slide. I'm going to move through this really quickly. We have in the patients that we've seen, Kara and I and several other clinicians, we've put them into a registry, gathered information on them. We've looked at their post-COVID scores of where they started with. Remember, 4 means you can't do anything. 3 means you need significant support. 2 means you need some support. 1 means you have symptoms, but are able to accomplish your ADLs. And we're seeing a significant improvement going from an initial score of 2 to 1.2 with the post-COVID function score. Next slide. We also looked at the PROMIS scores, looking at those domains of physical function and social interaction, which we expect to improve, which we see, and then those domains of looking at fatigue, anxiety, depression, sleep dysfunction, and pain, which we expect to decrease, which we see in all of those cases. Next slide. So we see improvements across all of the domains. We see improvements in post-COVID function scores. We see near about half of the patients who've had a complete resolution of what's going on. Now, what's really fascinating as we look at the data is that the average time I mentioned earlier of the people who are in our cohort is 657 days, which is about 21 months. 1 year and 9 months is the average duration of time that from their initial infection with COVID through their entering into our registry. So these people have had it for a long period of time, 20% less than a year, 40% 1 to 2 years, 40% greater than 2 years period of time. And while Laurie showed the data from Medscape of only 6% of doctors saying that they see that their patients that they have tools and their patients are able to get better, I guess we're in that 6% because we're seeing improvements that are happening across the board in these patients. And so we're pleased to be able to report that. We're continuing to add more people into our registry. And next slide, we want to give a chance for, I believe it's Alex or Laurie who are going to talk about the protocol. Thanks.
As part of this overall, oh, sorry, I just got a notification here saying my mic is muted, but it's actually not muted. Part of what FullScript's role in the application of this protocol is obviously to allow practitioners like us to be able to prescribe the supplements of this protocol to their patients. But as I'll show you in a moment, what we've also tried to do is include numerous resources with the application of that protocol so that they're getting an abundance of content to learn about the dietary and lifestyle recommendations as part of the application in this. So next slide, please. These are the suggested products here. And what I tried to create here as a visual is the flow in which you go to apply the protocol within the FullScript experience. So I'll explain in a moment where you actually start this process, but just to highlight here again, what you've just seen presented by Drs. Hanaway and Parker is the evidence behind the ingredients in these suggested products. These are products that plug in well to this protocol, and therefore we've combined them into an easily applicable protocol that you can then automatically use on FullScript. So protocol first takes you to the template page within FullScript, and then from there you can build a plan and send it to a patient. It's very easy. You should be able to do it within a matter of a few clicks. Next slide, please. Now this is very small, so you may have to see this separate from this presentation here. If you look at the recording after or the slides, you can zoom in a little bit, but there's 3 pathways to applying this protocol. The first is to use the protocol link, and we'll talk in a moment about the resources page on ovationlab.com, where that link or the 2 links for the 2 different protocols are stored. From there, it'll take you to the template section within FullScript. You'll confirm that this is the final template that you want to apply, and then you can build a plan from there. You'll notice that there are some changes happening in FullScript right now to the platform, where when applying the plan, you can either do it as a one-on-one plan or as a multi-patient plan. And from there, if it's beneficial, you can also share it as a link to be used with your patients in a broader sense. The second pathway is to go to the FullScript protocol library. That's fullscript.com/protocols. And in there, if you go to influencer protocols at the bottom, that's just the name of the section, you'll see Ovation Lab is listed as a partner. And there's the 2 protocols posted in there, the specialty protocol and the foundational protocol. The specialty protocol is one you just saw with the 5 baseline products, and the foundational includes the additional products that Dr. Hanaway talked about in terms of the various ingredients that would be beneficial along with those core ingredients. Once you're in that page, you would then go to apply the protocol, and it would take you through the same steps that we just talked about, to the template page and then to the build plan page. What's coming soon, and I'm excited to announce this because we've been talking about this now for nearly a year, is that we're going to be uploading this protocol into the in-app FullScript protocol, so that you have the out-of-app, the outside of the application protocol library in the marketing site, fullscript.com. And then you have the in-application, where most of us spend our time writing treatment plans for our patients. In there is the protocol or the template library, and we're going to be posting this protocol there so that you can more easily access it. Next slide. So here we just posted some easy links. These are, again, the links that were on the Ovation Labs resources page. The first link is, if anyone is watching and doesn't currently have a FullScript account, you can click this link. It'll create an account, and by using this link, we'll know that you're coming from this content, and so we can support you as needed if you need support related to this protocol. The next two links are related to the protocol itself. So you've got the specialty only, which are those 5 products, and then the entire, the foundational protocol. And then you can also make, as I mentioned, the protocol public or shareable, and this is an example of that. Next slide. And now we'll move on. I'll bring Lori back in. Here we go. And she'll talk about the resources section on the Ovation Lab website. Lori, I can't hear you. Oh, there you go. Now I can hear you.
Okay. Anyway, I want to just give a brief preview of the ovationlab.com resources page. So what we've done here, next slide, is built out and loaded all of the replays for the workshops that we've been doing over the last 6 months or so. We've included here both practitioner and patient resources. As Alex just said, there are links here for the full protocol, the specialty protocol, and the supplemental protocol, as well as examples of the surveys that we're using to gather outcomes data. Next slide. We also have built out a very, very robust, as Dr. Parker mentioned, set of links for the lifestyle resources. Again, these are things, our intention is for you to be able to use these and forward these to your patients to make the application of this program and protocol as easy as possible for you. Next slide. So given our time, I'd like to ask Kara and Patrick to come back on stage, and we're going to try to do a couple rapid fire questions. And I think, Sarah, we can stop sharing slides because we've come to the Q&A session. So Patrick and Kara, just briefly, there have been a few questions, and again, for the sake of time, I'm hoping we can do rapid fire. So Patrick, let's start with you, and then we'll ask Kara to comment on, is this protocol appropriate for applications with adolescents or in a pediatric population? Oh, you're on mute, Patrick.
Okay.
There we go. Yep.
I would say in adolescents for sure. No issues with that. A little less clear with things like the Grumwell route in patients under 7 years of age, but 8 and above, I see no issues with it.
Okay. Kara, anything to add?
No, I think that's right.
Okay. Kara, let's start with you on this one. There's a question about how to really help support your patients that are experiencing POTS.
Mm-hmm. Yeah. I have a number of people who I've followed for 3 years with POTS, and working with occupational therapy, respiratory therapy is really important. So actually, some of them are just finally starting to feel like they're turning the corner on this. Protocol supplements have definitely been helpful, a couple of them in particular, but that in combination with progressive training, as well as compressive garments, as well as, getting in plenty of electrolytes and, all of the things that specialists would do with that. So I've found the protocol plus working with a specialist and time has been helpful for some of my really sick patients with severe POTS.
Patrick, anything you want to add to that?
Well, I agree with Kara, and I would just say that the two drivers that I see are mitochondrial dysfunction and being able to support that, as well as the endothelial glycocalyx and repairing that those are the key aspects in POTS.
Yeah. There's another question about microclotting issues, and how do you identify whether a patient with long COVID symptoms may be experiencing some microclotting issues? Patrick?
There's some specialized testing that has been developed by Dr. Pretorius, and there's a lab in Alabama, I believe it is, that is doing that. From my perspective, I'm presumptive with it, and so I'm going to use the agent that's going to help with the microclotting, the remnant sulfate, to be able to work on endothelial glycocalyx repair to help with that, and then see where we go from there.
Okay. I know we're at the top of the hour, so I'm going to thank you both and thank Fullscript and welcome Alex back to wrap us up. I do know, I think that even this will provide a link to this recording on the resources page. And it's really worth exploring, because all of these, both materials for you as practitioners, as well as resources and tools and handouts for your patients, are made available there. So thank you all for joining, and back to you, Alex.
Thank you, Lori. Thank you, Dr. Parker. Thank you, Dr. Hanaway. Great pleasure to have you. Much appreciated. I do want to note that there was a few questions that were not touched on, so we'll circle back after. We can maybe address those offline and then send them out with the notes after the fact. So just don't want to leave anyone hanging. I do want to say again how appreciative we are at Fullscript to be a part of this overall program and the protocol development and the application of it. It's definitely an area that we want to see more of in the industry, where you're taking a combination of ingredients and applying this kind of approach so that you can see the outcomes measured and be able to apply that in the long term. So kudos, and I mean that with the greatest humility, to all of you for developing this program, developing the protocol, and providing us as clinicians with the skills on the front lines in working on this. So thank you all again. Thank you to everybody who attended today. We will be sharing this recording along with numerous resources after the fact. And by all means, reach out if you have any additional questions. Thank you so much, and have a wonderful day.